My name is Dr. Chad Achenbach. I'm the Associate Director for the Robert J. Havey, MD Institute for Global Health. I'm an Associate Professor in Medicine and Preventive Medicine here at Northwestern in the Feinberg School of Medicine. So thanks for taking the time to join us today. This is our latest installment of the IGH Seminar Series. This one is titled Implementing the WHF and PASCAR Hypertension Roadmaps in Africa. How far and how well? If you can, take a moment to follow us on Facebook and Twitter. Our handle is @FSM Global Health. In addition, we welcome you to become an Institute member to receive all kinds of perks and special access to our specialized resources in global health and services that are really important, we think, to kind of research infrastructure in global health settings. So for more information on that, you can visit our website at globalhealth.northwestern.edu/members. And please sign up and become a member. So today we're thrilled and honored to have Dr. Dike Ojji join us. And so Dr. Ojji is Chair of Internal Medicine and an Associate Professor of Preventive Cardiology at College of Health Sciences, University of Abuja. He's also the Lead Investigator for their Cardiovascular Research Unit at University of Abuja. And he's Deputy Director at the Center for Undergraduate Research and the Institute for Advanced Medical Research and Training. Also at his own home institution of University of Abuja. So Dike holds an honorary visiting professorship as well, with a position at Cape Heart Institute, and that's in the Department of Medicine at the University of Cape Town in South Africa. His work spans widely, defining the spectrum of hypertensive heart disease and hypertensive pharmacotherapy in African populations to establish a system for hypertension and cardiovascular care at the primary care level in primarily low and middle income countries. And the idea is to inform national dietary sodium policy as well. So he's been involved in several multi-center studies. He led the Creole trial, which is in 10 sites in 6 sub-Saharan African countries, the results of which they presented at the 2009 American College of Cardiology Congress late breaking session, and then was simultaneously published in the New England Journal of Medicine. He's currently a multiple MPI on 4 NIH research training grants, including 3 with us here at Northwestern. He has a very prolific publication record with over 100 manuscripts published in high impact journals, including New England Journal of Medicine, Nature Medicine, JAMA, and The Lancet. Before I turn it over to Dike, I wanted to mention there will be time for questions following the presentation. And you're welcome throughout the entire talk, though, to submit those through the Q&A feature. So if you go to that Q&A feature at the bottom of your Zoom page, that's where we want you to put the questions in. As they pop up in your head, you can go ahead and place those in there, and we'll address those at the end of the talk. With no further ado, I hand it over to Dr. Ojji.
Thank you very much, Chad, for your very kind words, and I count it great honor to have been invited to give this talk, which is titled Implementing the World Heart Federation and Pan-African Society of Cardiology Hypertension Roadmaps in Africa, concentrating on how far and how well. I do not have any disclosures, and I'm following this outline, starting with an overview of these roadmaps and rounding off with some lessons which we have learned from ongoing studies before concluding. It is well known that cardiovascular disease is the world's largest killer to date, and it accounts for over 18 million deaths annually, which translates to about 33% of global mortality. The very unfortunate thing is that it accounts for 70% of death in persons that are young, between the ages of 15 to 49. It is also well known that hypertension is a major driver of cardiovascular disease all over the world, and it's been estimated that hypertension and its complications account for over 10% of global health costs. Because of the burden of cardiovascular diseases, the World Heart Federation has come up with a lot of roadmaps to address either the risk factors of cardiovascular diseases or established cardiovascular diseases. And this includes the hypertension roadmap, And these roadmaps are really global frameworks, which are informed by evidence, by health system, and policy approaches. And they help to identify roadblocks and suggest evidence-based solutions that could be relevant in different contexts. And overall, they help to assist leaders in cardiovascular health to assess needs and gaps in their very own communities. The need for these roadmaps cannot be overemphasized, knowing fully well that we know the causes of cardiovascular disease, but in spite of that, and also the fact that we have very cost-effective treatments, there is still a very large evidence practice gap. So this needs to be tackled. So amongst this roadmap, like I said earlier, is a hypertension roadmap. The first World Heart Federation hypertension roadmap was in 2015. And in 2020, it had to be updated, obviously because there have been new developments in the field of hypertension, including new clinical guidelines from the American Heart Association to the American College of Cardiology guideline, to the European Society of Cardiology, European Society of Hypertension guideline, even to the International Society of Hypertension guideline. There have also been different programs like the WHO Global Heart Initiative, the Resolve to Save Life programs, inclusion of single pill combination into the essential medicine list of World Heart Federation, and different advances also in practice of cardiology, of hypertension as regards telemedicine and also mobile health. And in addition to that, different societies like the Pan-African Society of Cardiology, the Colombian Society of Cardiology, and other cardiology associations have also had different experiences that they felt to be very important in updating the 2015 roadmap. One of the key points in the 2020 World Heart Federation Hypertension Roadmap is identification of obstacles that will effectively prevent the management and control of hypertension. Now, these very roadmaps or obstacles rather are divided into two parts. One is on the demand side, that is the patient side, and the second is on the supply side. And for the demand side or the patient-centered obstacles, this is further divided into three, which are pre-diagnosis, start of treatment, and drug therapy, and also follow-up treatment. You can see that for pre-diagnosis, one of the obstacles is low awareness amongst patients and also low access to screening, whereas start of treatment and drug therapy, one of the key obstacles is inability to afford these medications, whereas for follow-up and retention, many patients have competing factors that will make them not to come for their follow-up. Whereas on the supply side, things like low screening, inaccurate measurements, and lack of diagnosis, ability of healthcare workers to make diagnosis because of poor training is part of that. And that also gets into poor awareness and understanding and use of guidelines in most of the primary care clinics. So the World Heart Federation hypertension roadmap did not just stop at obstacles, but the good thing is that it's also profiled potential solutions to overcome these obstacles. There are up to 10 of them. For example, number one talks about developing a population-wide prevention and control program, which includes availability and distribution of essential medications, to things like number 5, trying to promote and implement task sharing and team-based care. You will see these are some of the strategies we are using in some of the studies that I will show you later. And the 6th one talks about delivering care that is actually centered, around the people. And number 9 talks about trying to maintain a supply chain, which is very, very important in the management of high blood pressure. Now, to actually distill these roadmaps down to countries, the World Heart Federation normally organizes different roundtables, which are actually national fora to identify barriers and solutions to prevent cardiovascular disease. And they definitely use these roadmaps as guidance. And in Africa to date, we've had 5 countries benefiting from these roadmaps that include Ghana, Kenya, Mozambique, from Nigeria, where I live and work, and also Uganda. And these roundtables actually gather different stakeholders from cardiovascular scientists to practitioners, and also very importantly, policymakers who are going to buy into some of these strategies. So after each of these roadmaps, each country is supposed to come up with action points. Kenya was the first country that World Heart Federation had this roundtable in Africa. And after that, they came up with 4 action points, which include empowering people living with non-communicable disease to creating an enabling environment for task sharing in the management of cardiovascular diseases. Meanwhile, in 2014, the Pan-African Society of Cardiology convened a meeting in Nairobi, Kenya, actually to address the burden of high blood pressure in the continent. And one of the outcomes of that meeting was the production of what we call the Pan-African Society of Cardiology Roadmap on hypertension. And the aim of this roadmap was to achieve 25% hypertension control in Africa by 2025. Now, this roadmap has 10 priority actions to reduce the burden of hypertension in Africa by 2025. And they range from including hypertension in all NCD programs to things like integrating hypertension into already existing systems. We know that one of the systems that have really worked in Africa is treatment of HIV. So leveraging on such systems for immunization or antenatal care at the primary care level could be one way to go to actually reduce the burden of hypertension. It also includes things like task sharing, or just task sharing or task strengthening, because we know with the data of physicians in lower and middle income countries, there is no way we not adopt or adapt task sharing if we're going to really manage NCDs. And it goes down to number 10, and you can see there that there has to be a lot of investment in population interventions. And these are some of the strategies I will be showing us that we are trying to implement in some of the studies that are currently ongoing in Nigeria and other parts of Africa. Meanwhile, according to WHO's and the CASA Permanente North California study, there are 5 crucial components of effective hypertension care, especially at the primary care level. The number 1 thing is that you need a simplified protocol that is very simple. The non-physicians and primary care physician can follow easily. There is need for good medication supply. Thirdly, it has to be community-based treatment. Taking health to the community is one of the best ways to distribute health to the people. And the 4th thing is patient-centered, empowering the patient to know their number, to be able to measure their blood pressure. And 5thly, we need a good information system whereby the data of patient can be captured longitudinally, patient can be followed up, and can also be recalled to the clinics. So in 2019, we started a work called Transforming Hypertension Management in Nigeria, and actually based on the WHO, HARTS, and also the CASA Permanente North California study. And it is funded by NIH under the RO1 mechanism, and it's a collaborative work with my university, University of Abuja, Washington University in St. Louis, where my co-PI, Dr. Mike Hoffman, is, and of course, Northwestern University. We're working with people like Lisa Ishon, Abigail Badridge, and also Nami Kantula. And this, like I said earlier, pattern after WHO Acts, and also the CASA Permanente study. And overall aim is to build a system for hypertension care and treatment that is centered on patients and non-physician healthcare workers rather than physicians, because of the death of physicians. So the formative aim 1 is to develop implementation pathways and intervention packages for 2 aspects of this study. The first one is for a system-level, large-scale hypertension program adapted from the KPCN model in public primary healthcare facilities in the Federal Capital Territory. And secondly, to develop an additional patient-level health coaching, including home blood pressure monitoring, led by community health workers in a sample of these facilities. Whereas aim 2, which revolves around effectiveness, is to evaluate effectiveness of this system-level hypertension program, like I said earlier, adapted from the KPNC model, and secondly, also to evaluate the addition of patient-level coaching, including home blood pressure monitoring in individual level blood pressure among a sample of high-risk patients. And while the third aim is to evaluate implementation of this multi-level intervention through the REHAM framework, and also to look at the costs of this system-level program and addition of a patient-level health coaching, including home blood pressure monitoring. So our implementation strategies, I said earlier, is based on the WHO's and also the Kaiser Permanente Northern California model. Also trying, also incorporating as much as possible some of the policies or key points in the World Heart Federation roadmap, and also the PASCAR roadmap. So it revolves around 5 aspects: standard treatment protocol, and we are using a protocol that has been developed by the Federal Ministry of Health of Nigeria. I'm going to show that later. Patient registration and empanelment, making sure that every patient that comes are well registered. They are assigned to a clinic whereby they can be followed up, then push for utilization of fixed dose combination, which of antihypertensive medication, which has been found to improve compliance and thereby have a better way of controlling blood pressure compared to individual drug combinations. Then encouraging a team-based care approach. And fifthly is home blood pressure monitoring and health coaching. No, I don't expect us to read it, but this just tells us some of the similarities between our own strategies and those of KPNC and WHO's. Like, for example, the KPNC intervention component actually utilizing an algorithm which was developed by that team. And similarly for us, we also use a simplified treatment protocol, which is developed by the Federal Ministry of Health. Now, the KPNC study also promotes a lot of use, push for the use of single P, or what some people call the fixed dose antihypertensive combination. And this is also part of our strategy, whereas the KPNC combination revolves around lisinopril, which is an angiotensin converting enzyme inhibitor, and hydrochlorothiazide. Ours revolves around amlodipine, which is a calcium channel blocker, and losartan, which is an angiotensin receptor blocker. The KPNC also promoted the use of non-physician, using what we call physician assistant. But for us, we don't have physician assistant in Nigeria. So the best we could use was community health extension workers, and in some cases, community nurses. Then for the WHO, there's a lot of push for team-based care, and that is what we have promoted in our study. So in our study, we have community health extension workers working closely with pharmacy technicians, and also working closely with information officer, with a facility manager who oversees, what they are doing, and then with a monitoring team from our researching that visits every 3 months and see if there's any need for retraining, any need for vetting, and so on and so forth. So the overall aim is actually to build a system, a lasting system that is owned by the people, that is maintained even after the study. So we use this simplified protocol. So it was developed in August 2018 by the Federal Ministry of Health, and it is based on using calcium channel blocker combination therapy. And this was informed by the CREO study, which was in 6 sub-Saharan African countries, 10 sites in 6 sub-Saharan African countries. Now, before we started, we did a feasibility study, like a pilot, to look at the feasibility and effect of community health worker support and home monitoring for blood pressure control in Nigeria. And we found that, wow, this is very, very feasible. And that was published in the Cardiovascular Journal of Africa. We also choose out of the 244 public primary healthcare facilities in the Federal Capital Territory of Nigeria. We choose 60 of these facilities, and this was, we used a stratified random sampling technique in addition to some other criteria that, for example, such site must have 2 full-time staff before they could be considered. Then we also carried out capacity and site readiness for hypertension control using what we call the SERA document, modified SERA document from WHO. And then in addition to that, we also engage different stakeholders to know their perspective and adaptation of hypertensive treatment program, especially that is based around non-physicians and not physicians. To ensure effective implementation, we do a lot of training. So the upper one here, training in the primary healthcare, also training in our facility at the University of Abuja Teaching Hospital. So, and the aim of this is to really build capacity amongst the people or the community health workers as much as possible. We also do quite some monitoring visits, and this picture shows Lisa there. You can see Lisa McHoffman is at the back. That is a big battery, and myself and some of our team members when we visited one of the primary healthcare facilities called Hagini Primary Healthcare Facility, and we utilize these treatment cards and enrollment card to capture our data, and these data are now transferred to University of Abuja RedCap. We also do a lot of stakeholder engagement because I'm meeting with policymakers. Because of buy-in, we want this program to be maintained and to be a fulcrum for other states to actually implement hypertension or integrate hypertension into their primary health care. So in one of those visits with Lisa, with Nami there, and Mark, we visited the Executive Secretary of FCT, that's Federal Capital Territory Healthcare Board. The Healthcare Board is the one that oversees the activities of the primary healthcare. We also had opportunity also visiting, to your right here, the NCD coordinator, or that is a non-communicable disease coordinator of the Federal Ministry of Health. And then we do a lot of community mobilization using community health officers and community promoters who are actually employed in this primary healthcare. So we leverage, their expertise and to reach out to the people after training them. And we have over 270 of such community mobilization in the last 3 years. So how far have we gone? So as of April the 30th, we have over 20,000 patients from these 60 primary healthcare facilities with over 120,000 visits. And the mean age at baseline was about 49 years, and blood pressure control, that is blood pressure of less than 140 over 90, 140 systolic, 90 diastolic, was 11.5%. So this talks about blood pressure lowering medicine. How did it fare when patient visited at baseline? I want you to concentrate at this second column, that is at the time of registration. At the time of registration, we found out that about 58% of our patients who were on one form of medication or the other. And out of those 58% that were on one form of medication or the other, about 57% of them were just on single medication, whereas about 36% of them were on 2 medications. Now, calcium channel blocker was the medication that was most used in about 83% of those who were on medication, followed by diuretics. Then when we looked at our cross-sectional data versus the longitudinal data, what we found that by February 2020, compared to April 2023, the blood pressure, systolic blood pressure, has reduced by about 9 millimeters of mercury. And then when we talk about the control rate improved from 21% to about 47%. And when we looked at longitudinal data, per visit. So from visit 1 to visit 24. As of April 2023, we found out that the blood pressure has reduced. For systolic blood pressure has reduced by over 20 millimeters of mercury, from about 152 millimeters of mercury to about 129 millimeters of mercury. And control rate has increased from about 14% to about 72%. Now, this slide talks more about the need for follow-up and retention when we manage this type of patients. And we can see that last visit among those who followed up in the last 3 months, the hypertension control rate was about 53%, compared to just about 32% for those who have not followed up in the last 3 months, showing that more frequent follow-up is definitely associated with higher treatment rate, higher control rate, and also lower blood pressure. And then still talking about retention, so Jian Chen, who is a member of the team, as part of his PhD, worked really on retention. And very glad to say, I'm very appreciative that this work was actually funded by the Global Heart Catalyzer funded as part from the Havey Institute. And Jian Chen showed that in 19 months, the retention rate was just about 41%. And there was also wide variability across primary healthcare centers. I don't expect us to read this because it is quite busy, but please concentrate on the bottom part of this. And what it shows is that over time, from the second quarter of 2020, when we started our program, down to about the second quarter of 2022, after 2 years, we can see that medication supply, so in each facilities that had 30-day dose supply of antihypertensive medication from amlodipine to losartan to hydrochlorothiazide, increased from 20% to over 78%. And I want to say at this point that initially, over the first 9 months, what happened was just a registry phase of it. So there was not much intervention. So patients just had the leverage to get their medications from the community pharmacies. After that, for the next 18 months, these medications were provided free up to about second quarter of 2022. Then we finally stopped free medication and then went into what we call the drug revolving fund, whereby patients pay, but not as much as they pay in the community pharmacy because they buy in bulk, and some of them drug companies are ready to give them at lower prices because as part of their social corporate responsibility. And so at this point, you can see that the 30-day stop in those 78% of them have up to 30-day stop compared to 20% when we started in 2022. Now, one of the problems or arguments people bring about when you talk about management of hypertension at the primary care level, especially in low and middle income countries, is issues of safety. So is it safe to actually start antihypertensive without doing, for example, electrolyte, urea, and creatinine for these persons? I think the 2020 WHO practice guidelines settles that issue. And it said that when starting pharmacological therapy for hypertension, the World Health Organization suggests obtaining tests to screen for comorbidities and secondary hypertension, but it is only when testing does not delay or impede certain treatment. So when testing is when it's not available, it is very, very safe to start antihypertensive medications in patients. And to prove this, we took the profile of 400 of our patients, 200 of them on fixed dose combination and another 2 on free combination. And we were looking at their electrolyte, urea, and creatinine values before starting therapy and 6 months after starting antihypertensive therapy. And there was virtually no difference in their electrolyte, urea, and creatinine level. Even when we calculated the estimated glomerular filtration rate, there were no differences. We're also carrying out an own blood pressure monitoring as part of this study. And it's actually to evaluate the implementation and effectiveness of community health extension worker-led health coaching and low blood pressure monitoring and hypertension control risk among high-risk patients with uncontrolled hypertension. And these high risk, we have defined them based on our findings from our formative work, our registry, that patients with elevated blood pressure still have systolic blood pressure of 140 millimeters of mercury and above, or diastolic of 90 millimeters of mercury in spite of treatment, patients who are 50 years and above, and patients who did not complete high secondary school education. We found out that these factors were associated with poor control, in our baseline data. I mentioned earlier on the hypertension, what we call the drug revolving structure. So we have to leverage this. And meanwhile, where there is no much insurance coverage, with less than 10% of the population having insurance coverage, we have to leverage what we call the drug revolving fund structure, which was initiated by the African Union in 1980 in Mali, in Bamako, Mali. And the essence is buy in bulk and then make it cheaper for the patient, so the facilities can collect when they buy in bulk and make it cheaper. So presently, we are running this with this primary healthcare center, that's our study team, with the intention of handing over ownership to them after the study. Apart from this main study, we've had some other sub-studies. During the peak of COVID, we actually, using a dry blood sampling technique, looked at the IgG seroprevalence of SARS-CoV-2 among 525 for our frontline health workers, both in my teaching hospital, the University of Abuja teaching hospital, and the primary care. So by July 2020, we found out that 31% of them were seropositive. By September 2022, 45%, then December 70%. But the most interesting thing, and most of them were asymptomatic. It was only one of them that was actually admitted, and none of them died. There has also been other sub-studies related to substandard falsified medicine, led by Grace Schedule. There have been also work ongoing on drug revolving fund being led by Lisa, Grace, and Eugenia, who are members of the team. And then there have been a publication also on fixed dose combination, looking at comparing the dose on free combinations versus those on fixed dose combination. We've been blessed with over 10 publications, since we started the study in 2019. So what actually the next steps? Number one is to evaluate overall implementation and effectiveness analysis with corresponding publications. So looking at effectiveness, implementation outcome, including effectiveness and implementation of own blood monitoring and health coaching, patient level intervention. So holistic, evaluation of our program. We want to collect and publish end of study qualitative data to explore and explain variability across age, sex, and urban and rural groups, and complete and publish other sub-studies that are currently ongoing. Ours is not the only study going on in Nigeria around hypertension. There is a Nigerian Hypertension Control Initiative. I sit in the board of this study, and it is championed by Result to Save Life in collaboration with the Federal Ministry of Health. They are working in 2 states, Kano, which is up north in Nigeria, and Ogun State, which is down south. And they're working in 104 primary healthcare facility, 52 per state. And they have enrolled today about 22,000 patients on that treatment list. And there's also another study funded by AstraZeneca, which is run by Population Service International. It's a non-governmental organization, and they're working in 18 states of Nigeria in 20 to 30 facilities per state. And in Ghana, there have been some work at land task sharing and shifting, led by Professor Benga Ogedegbe, and they are making so much progress trying to establish a system that revolves around non-physician, especially management of high blood pressure. Now, one of the 10 priority points, if you remember very well, in the Pan-African Society of Cardiology roadmap, is actually to leverage on already established system. And one of the systems, like we know, that has been well run in the African continent and a lot of low and middle income countries is the HIV system. And so there have been some studies around this, and it's under a consortium funded by NIH, which is a UG3 UH3 program, and we have 6 countries in that consortium of Nigeria, Uganda, Botswana, South Africa, Zambia, and Botswana. And for us, we're working in South Nigeria, and our study is titled Managing Hypertension Among People Living with HIV and Integrated Model. And we are evaluating the effectiveness of practice facilitation. So practice facilitation is actually using people that are quite experienced in the system, either retired or still working. So we are using nurse clinicians that have worked over the system for 30, 40 years who are now retired, and using them to build a system to strengthen a system for hypertension among persons living with HIV, and then using that to integrate hypertension management into those primary healthcare in Akwa Ibom State. There are also other studies like the Polesa in Uganda, run by my good friend Fred Samatilia, who is a contact peer, where they're trying to strengthen blood pressure care and treatment cascade for those in Uganda living with HIV. There's also another one run by Anna Mukumbi, who is in Mozambique, also around hypertension and HIV, and also in Botswana, integrating hypertension and cardiovascular disease care into existing HIV service. So really, really trying to pay out the priority strategies of the Pan-African Society of Cardiology roadmap, hypertension roadmap. One way to actually manage hypertension in any society, especially in the low and medium income, is to build capacity among healthcare practitioners. And for the Pan-African Society of Cardiology, they started a certificate course, which has actually been in limbo for some time. I hope it to be resuscitated. It's a course in hypertension collaboration with Public Health Foundation of India, International Society of Hypertension, British Irish Hypertension Society, and CETA for chronic disease, and trying to train primary care physicians so that likewise they will also be the one that will train other persons in the primary health care, especially non-physicians. So it's more of a TOT, train the trainers model. Then one of our investigators, Abigail Badri, as part of her PhD, is working on the ECHO model, leveraging the ECHO model. So the ECHO model talks about extension community health outcome model, first developed by University of New Mexico. It was actually to improve care in complex chronic health conditions, but Abigail is now leveraging that in management of hypertension. So this care goes around the hub, scope mechanism whereby you have experts, working with community practice people to actually train, a number of persons. So it's an online program, and I think we've had over 7 of such sessions, and each of those sessions have been attended by over 100 primary healthcare physicians. So the community of practice are people that will present cases, talk about what is happening in the environment. Of course, the experts get on topics. For example, they can talk about complications of hypertension, non-pharmacological management of hypertension, whereas they are participants who will now ask questions, and also assess the program, at the end of the program. And there's also currently a mobile app which we are testing with result to save lives and Johns Hopkins. And this mobile app actually requires very low bandwidth. And the other thing about it is that it is self-paced, so that different categories of healthcare worker, depending on their ability, to assimilate time, can actually adapt and take this course. And at the end of this course, there's questions also. At the end of each module, there are questions that they answer to test how well they have comprehended this topic. So this is still at the pilot phase, and is being tested in the Federal Capital Territory, and our team has been quite instrumental in helping to do that. So one of the things that has actually favored some of the work going on in Nigeria is that we have some favorable policies. Before this time, task shifting and task sharing policy was actually restricted to communicable diseases and not to non-communicable diseases. But these have been updated in recent times to non-communicable diseases. So we have a policy now that empowers the non-physician healthcare worker to be able to treat non-communicable diseases or risk like hypertension and also diabetes. There's a need to engage the right stakeholders. The need for it can never be emphasized if we're going to really build a system and we're going to actually work out the priority areas that we saw in the PASCAR and the World Heart Federation roadmaps. And in the managing hypertension for persons living with HIV, the stakeholder, the chairman of our board is the Honorable Commissioner, who is like of health, who is the #1 administrator for health in that state. And this was during one of our board meetings for the hypertension treatment in Nigeria, in Abuja. And members of our board and member both of the states, healthcare board, the public health, and also Federal Ministry of Health. So making it very easy for us to discuss and to be able to translate most of the data and the results we're having into policy. So engaging policymakers early and throughout the study is really the key to it. So we are the NCD, that's a new NCD coordinator. Well, this was like a policy meeting, and also in one of our policy meetings also at the state level. And this was actually in Ghana with policymakers and scientists. And this is another meeting that was in Mozambique. In addition to our hypertension study, we are also trying to define the sodium level in food and also in the population in Nigeria with the ultimate aim of actually developing a sodium limit or salt limit in the Nigerian population. And that work is in collaboration with World Health Organization and also with Resolve to Save Life and Federal Ministry of Health. We have 3 aspects of the study: the stakeholder interview, what we call the retail surveys, and also population survey. We are also currently working with the George Institute, looking at the evaluation of a triple single pill combination. It is well known that most patients are never controlled on 1 pill. A number will not be controlled with 2 pills. So quite also a number we need 3 pills. So we're looking at 3 pills of amlodipine, telmisartan, and indapamide compared to what we use at the primary care level, which revolves around amlodipine, losartan, and hydrochlorothiazide. As I begin to round up, one of the things we want to do is really to build capacity. There's no way you can be sure of sustenance if you don't build capacity. And because of this, this is a D43 award titled Cardiovascular Research Training in Nigeria. The contact PI for this is Professor Lisa Ishon, and our main objective is to build a capacity and experience in cardiovascular research at first in University of Abuja and other parts of Nigeria, so that they will be able to design and conduct implementation science, clinical trials, and patient-centered care. And part of this program, so we have PhD in global health sciences. So we have 2 of our team members, Dr. Gabriel Shedu, I'm sure it's in this meeting, and Dr. Emmanuel Opetu as PhD students, and postdoctoral research fellowship. We have 2 persons who will be coming to Northwestern, I'm sure very soon, to spend like 6 weeks to 3 months. And those are another team member, Anthony Ojji and Chidebele Ojiku. And then we have Dr. Vosit, who is doing a master in regulatory compliance, and another person, Nana Ripie, who is doing a master's also in global health program, also in Northwestern University. So always grateful to Northwestern University. The partnership has been great, and I think it's going to improve and increase more and more as time goes on. So as I conclude, the World Heart Federation and PASCAR Hypertension Roadmap provide the best frameworks for the government, policymakers, healthcare providers, and leaders in cardiovascular health in the African continent to tackle the burden of hypertension and its complications. Ongoing studies show the feasibility of implementing priority actions of both the World Heart Federation and Pan-African Society of Cardiology Hypertension Roadmap in the African continent. However, the need for high-level advocacy so as to ensure buy-in by relevant stakeholders, various governments, and African Union cannot be overemphasized. So I remain very grateful to NHLBI for the funding. My very good friend, Mark Hoffman, and his team in WASU. Of course, they are some of the best people you can really work with. And the NU team, Lisa Ishon, Nami, Kandula, Bigger Badrich, and everyone. Of course, to Havey Institute, they've been funding a number of our sub-studies. And SCT board, Federal Ministry of Health, Result to Save Life, our advisory board has been fantastic. Our data safety and monitoring board has just been wonderful. And I have a very strong team. This is part of them. We have about 30, in our team. This is just part of this. Wonderful people. They are very, very grateful. They keep on moving things forward. And I remain very, very grateful to them. So thank you very much.
So thank you so much, Dike, for a just unbelievable tour of all the work that's been doing, and really from the start of thinking about the individual person all the way through to the policy that's needed at the national and at the global level. We have a couple of questions, so I'm going to read them. And so the first is from Philip Gorlick. Professor Ojji, thank you for the most informative and important presentation. In relation to the non-physician healthcare workers, can you tell us, 1, eligibility criteria used to select them, 2, how they interacted with study and non-study physicians? Thank you.
Good. All right. Okay. So thank you very much. So for eligibility criteria, on the average, most of these primary healthcare centers have full-time staffers who are community health extension, maybe 2 or 3. So the issue of selection doesn't come in there at all in selecting these people. 1, they must be, for our study, the HCN study, the priority people are community health extension workers. Where we don't have community health extension worker, we can use community nurses in priority. So on the average, you see that there are about 2 or 3 of them there. So there is no issue about criteria selecting them. We just train, we just try as much as possible to train all of them. So there's no need. But where we have big facilities, because there are some other ongoing work, in such facilities, we make sure as much as possible that no one person is involved in 2 or 3 projects to say. So we have to make sure as much as possible that if you are tied with another project for those big facilities, then we have to exclude you, from the HCN study. So those are some of the criteria that we have used. There's another question, Lisa. Remind me.
It was how they interacted with the study and the non-study physicians.
Great. Yes, great. So for this study, for the study physicians, so when we say study physicians, we have 2 groups of persons. We have our research team, and our research team also comprise those that work, physicians that work in the primary healthcare level. So what we do is that for the primary healthcare physicians, they are part of the study. We empower them to be part of the monitoring team. So in terms of interaction, it's a 2-way thing. So if you have complaints, you have difficulties, you can get straight on to your primary care physician. Remember that there are very few of them. So for example, for these 244 primary healthcare centers, I don't think there are more than 10 primary care physicians manning these places. So there are very, very few of them. Now, so in terms of interaction now, when we train, in the trainings, in the larger training, we make sure that the primary care physicians in those primary care facilities are part of the training. So we empower them to be part of people that we monitor and to be able to train and to mentor these persons. Then we also have our physicians from the team, from the teaching hospital, coming in every 3 months. And what they do is in a way of monitoring visit. And it's 2-way thing. We want to see what they are doing. We want to do on-spot retraining as much as possible. And sometimes also, we have to bring back these persons to our teaching hospital to train. And along the line, we have seen the effect of this. So the quality of data has kept on improving over the time. So the relationship has been very, very good, very, very good. And that is because initially we engage everybody in the focus group discussion, in the in-depth interview. Both the community health extension workers were involved, community nurses were involved, the primary care physicians were involved, what we call the director of primary health care, who actually overall administer these primary health care facilities, were also carried along. So, and really engaging the real stakeholder, and that has made things quite easy.
Great, thank you, Dike. I'm going to give you the next two together. So the first is from Darwin Labarth. It says, Professor Ojji, sorry, thank you for an outstanding presentation and congratulations on your progress to date. Have you a time-specific target for Nigeria or for Africa, analogous to the World Heart Foundation 25 by 25? And from Dr. Claudia Hawkins, if I read the slides correctly, around 58% have BP control. How does this compare with other African or even non-African countries? What do you think is the biggest barrier to optimal control currently in your setting?
Thank you very much. Great question. So, of course, ours is a program we are trying to implement strategies which we think can work very well. And remember that this is funded, so we do a lot of training and retraining. So, but now translating this into real practice, yes, it can work. Result to Save Life are doing also a program. I mentioned that in Kano and Ogun State. It's not as intense in terms of training and retraining, but they've had some success. I mean, their control is about 30%. It will not be up to what we have here. You know? Remember that control in most African countries have been less than 10%. So we can start somewhere. So the issue is this: it is very, very feasible, but then we need to build capacity. We need to build manpower. And that is one the Pan-African Society of Cardiology is trying to do. By the way, I'm the chair of Pan-African Society of Cardiology. So one of our strategies will be to leverage some of the successes we have had in Nigeria to some of these countries. And how can we do it? It's a primary care approach. Most of these countries don't have any form of NCDs integrated into the primary care. I think one of the things that has helped Nigeria now, we now have a policy that says that really NCDs can be integrated into the primary. So that is one thing we have to do first, having these policies, testing them, and then taking it off from there. But remember, it will require some time. It will require a lot of effort. So the interesting thing is that it is doable. It is very, very feasible, and it has to be continuous. Thank you.
Great, thank you. And I think the 58% is a lot higher than when we were first designing this study, where the overall population control was really like closer to 10% or so. And so I think this is definitely a sort of a goal of where this can be in the primary care center. The Ryan Family Primary Care Center at the Havey Institute's been, I think, very committed to thinking about how do we expand out primary care. We have time. We have one more question, and so Dike, if I can get you to maybe answer it in two. Oh, actually, we have two. If you can answer them in maybe 1 or 2 minutes, so I can give Chad back the mic for a couple of last end comments. So again, from Darwin, what is the primary outcome measure for the Nigeria sodium study? Improved control of existing hypertension or prevention of new cases of hypertension? And from Mohammed Hassan, thank you for summarizing the great work. I'm curious if you used an evaluation framework to guide your study evaluation and barriers in monitoring evaluation. And I think probably there's many studies that you talked about. I would suspect it's about the HTN study. So if you could maybe answer in maybe 1 or 2 minutes, I know a little bit of a challenge.
All right, good. So for this sodium study, we want to set a sodium target, and our plan, our overall aim is to prevent hypertension, primordial prevention, and maybe primary, secondary prevention. Those that have hypertension, you reduce the salt level in them, they get better control when they take their medications. And then for evaluation, so we are using the REAIM. So I mentioned that is a framework we are using to be able to evaluate, our program. So what are the barriers? I think someone mentioned that we have seen. I think the barrier has to do with knowledge, awareness, amongst healthcare practitioners. at that level, then also in the community. So we do a lot of community mobilization. A lot of people have wrong ideas about high blood pressure. A lot of people don't want to come to the facilities. They better, they go to, utilize other things. They don't just care. So to educating the people empowers them. And I think that is why it is patient-centered. So you have to really educate the people as much as possible. Create awareness about high blood pressure, because high blood pressure obviously, is the #1 risk factor for death all over the world. And now part of the world, from heart failure to chronic kidney disease to stroke, driven by high blood pressure.
Great, thank you so much. And Dike, again, it's such an honor and a pleasure to work with you, whether it's in the deciding what the exact measure is going to be, to how do we influence policy. And I've learned so much from you to really sort of look beyond the impact of a paper to look at the overall impact of the work to date. And I'm going to hand this over now to Chad to bring us to a close.
Okay, yeah, thanks everyone. Thanks again, Dike. Really a great talk, and really amazing that the work you've done and what you've accomplished. So again, thanks so much for joining us. We're really honored to have you to share your insights and expertise. So I also wanted to thank our audience for joining us and sticking with us the whole hour and submitting your thoughtful questions. We invite everyone to join us next month for our next IGH seminar. It's going to be a special in-person event. So a little bit different for us, but in-person event featuring our Northwestern honorary degree recipient, Dr. Agnes Bingwaho. So Dr. Bingwaho is a retired vice chancellor at the University of Global Health Equity in Rwanda. So she started her career as a pediatrician and then became really outspoken for her work rebuilding the post-genocide Rwandan health system. So really a pioneer in that whole area. And specifically, she led efforts to address the devastating effects of the HIV pandemic in Rwanda, and which led to her leadership positions and everything she did within the Ministry of Health. So we're really excited that we have one of our own global health experts who will be a Northwestern honorary degree recipient. So it's so exciting that this event will take place in person in the Searle Seminar Room at the Lurie Medical Research Center on Thursday, June 8th. So you can see on the slide here the time and date, and we welcome everyone to come and honor our honorary degree recipient. Again, thank you to everyone for joining us today. Thanks for everyone who registered. It really helps us if you can make sure you register. We have a recording of this webinar that we'll share by email for anyone who missed it or who missed part of it. This concludes our webinar today. Thanks, everyone.